Good morning. My name is Davis Baird. I'm the Director of Government Affairs for Hospice and Palliative Care at the National Association for Home Care and Hospice, or NAHC. We and our partners at the National Hospice and Palliative Care Association, NHPCO, are really pleased to have everyone here today to talk about something that we're all really passionate about, which is the Medicare hospice benefit. I also want to extend a special gratitude and thanks to Congressman Neil Dunn and his office and staff for graciously sponsoring this event and this room for us today. So as I said, we're going to be talking about the value of hospice and Medicare, the hospice benefit. We're going to cover what it is, how it works. We're hopefully going to dispel some misconceptions about it, some misunderstandings I think the public and maybe some policymakers have about the benefit as well. And we're really going to spend a lot of time diving into some new research from our partners at NORC that I think really more so than any study, any analysis about hospice that's happened in the past, this study really shows the value that the benefit drives. And it does that, of course, not just through improving the quality of life for people, at the end of their lives and their families, their caregivers, their friends, but also in the process saving the Medicare system billions of dollars every year. And again, it does that by doing what it does best, really helping people sort of end their lives in the most peaceful and pain-free way as possible. So just quickly, pro forma for those who aren't aware, the National Association for Home Care and Hospice, NAHC, is the largest nonprofit association representing providers across the care at home continuum, from Medicare home health agencies to hospice agencies to private duty nursing to home and community-based, Medicaid home and community-based services organizations. We have members in every state, in every district, and we're really passionate about advocating for public policy that ensures that people can get care where they want it, which we know is most often in their homes and communities. So with that, I'm going to turn it over to my partner Logan to introduce himself and our speakers.
Got to move this mic down a little bit lower. Well, welcome everyone. Thanks for coming. My name is Logan Hoover. I'm Vice President of Policy and Government Relations with the National Hospice and Palliative Care Organization, also with the Hospice Action Network. With us today, we have three really fantastic guests. First, Susan Lloyd. Susan Lloyd is a national leader within the hospice community. She serves as President and CEO of Delaware Hospice. Delaware Hospice is recognized nationally as a trusted hospice provider, providing end-of-life care, education, and support since its founding in 1982, which, for those unaware, is about as old as the Medicare hospice benefit itself. Susan serves on the board of the National Hospice and Palliative Care Organization and board chair of the Hospice Action Network, advocating to ensure that all Americans have access to high-quality care at the end of life. Also with us today is Dr. Joseph Shega. He's the Executive Vice President and Chief Medical Officer for Vitas Healthcare, the nation's leading provider of end-of-life care, and has likewise been providing hospice for over 40 years. He's board certified in geriatric and hospice and palliative medicine, and has been caring for, studying, and teaching about geriatric patients and end-of-life care since 1999. In his role of Chief Medical Officer, Dr. Shega oversees and leads the medical direction for all Vitas locations in 14 states and the District of Columbia. He provides leadership to all Vitas regional medical directors and oversees physician services. And lastly, Diane Munivar, Vice President for Healthcare Strategy at NORC at the University of Chicago. NORC is an objective, nonpartisan research organization regularly partnering with government, corporate, and nonprofits around the world to inform critical decisions facing society. In her role, Diane combines subject matter expertise and analytical skills with storytelling and evidence translation to support sound public policy. She specializes in maternal health, social determinants of health, health disparities, post-acute care, senior housing, and end-of-life care. So welcome, everyone. Thank you all for coming. I'm going to turn to Susan now to tell you a little bit about her role as CEO of Delaware Hospice.
I've had the privilege to serve as the President and CEO of Delaware Hospice for the last 36 years. Delaware Hospice is a not-for-profit, community-based organization serving the state of Delaware and several adjacent counties in Pennsylvania. Delaware Hospice was the first hospice established in Delaware in 1982. Hospice was a very new program at that time. The Medicare hospice benefit had created reimbursement for the first patient-centered approach to the care for the seriously ill. Hospice care is provided by an interdisciplinary team made up of physicians, nurses, certified nursing assistants, counselors, social workers, and chaplains who focus on creating an individualized plan of care for the patient and the family. The team is supported by volunteers who assist in implementing the plan of care by visiting with the patient or doing things to support the family, such as running errands. A true differentiator from other forms of health care is the focus that hospice has on the patient and the family as the unit of care. The plan of care addresses the physical, emotional, psychological, and spiritual needs of the patient and their caregivers. The hospice team provides the knowledge, education, and direct care needed to support the patient's wishes. The goal is to provide care and comfort while living with the disease. Hospice care is provided to people with a terminal condition, which is expected to result in months to live if the disease follows its normal course. Generally, that's around 6 months. The full benefits of hospice care are realized, though, when the patient and family have the opportunity to engage with the team who provides the support needed wherever they call home. Care is provided at home, but also in nursing homes, assisted living facilities, and hospitals as needed. Hospice is not a place. It's a way of caring for people and their loved ones as they are nearing the end of life. The Medicare hospice benefit was designed to meet the needs of patients through their journey and provides 4 levels of care and support. These levels are routine home care, where regular visits from the hospice team are provided in the home, respite care provided to the caregivers to give them a break from caregiving, which is also provided in the home, a facility or a hospice facility or a nursing facility. Continuous care, which is provided in the home when more intense care is needed to manage a change in the patient's condition. And finally, inpatient hospice care, the highest level of hospice care provided in hospice facilities, hospitals, and nursing homes. This level of care concentrates on 24-hour care and focuses on symptom relief. It is truly amazing how the Medicare hospice benefit was designed to provide the right care at the right time, all coordinated by the hospice interdisciplinary team. Another unique and important aspect of the benefit is that the care continues after the patient dies. The bereaved are provided services from counselors and volunteers to support them through their grief. This is accomplished through home visits, support groups, and other resources, and is usually offered a full year after the patient's death. Reimbursement is provided on a per diem basis, a flat fee for each day of care based on the level of care that's provided. The Medicare hospice benefit actually was the first at-risk benefit in the Medicare program. 24-hour access to the services of the interdisciplinary team, medications, supplies, equipment, all of these are provided by the hospice to support the patient's plan of care. Interesting that this has been in place for 40 years. It's where others want to go in healthcare. We know it delivers high satisfaction and it saves the Medicare program money. The opportunity is obvious for hospice providers to show others the way in a value-based payment system. Families who receive hospice care often say they wish they had come into the program sooner. Once they experience the expert care of the team and they know that they have been provided, and they know then that they have provided the best care for their loved one. The team's ability to provide comfort, to educate, and prepare the family makes all the difference in creating a peaceful end-of-life experience. So who benefits from hospice? How about I tell you about Sally? Sally was 64 years old when she was diagnosed with Parkinson's disease. She lived alone in a condominium. She had 2 small flights of stairs to get up to her unit. Over the next 5 years or so, her disease progressed. She retired from work. She needed frequent medication adjustments, suffered with depression and anxiety, had multiple falls from the disease, one which required a hip replacement. Daughter and son were the primary caregivers, both working full-time and raising their own families. Sally lived with her daughter for several months at a time when these incidents occurred. Although she appreciated the help, Sally was not at all happy to be dependent on her family. Finally, the decision was made to move her to a continuing care retirement community, mostly because of her personal safety and needing to have supervision by the staff there and get meals provided. Over the next couple of years, the disease progressed. She became not as ambulatory, she started to have memory issues, and the meds just were not working as well. The decision was made to enter hospice care. The team worked with her to move her to assisted living at that point, had regular visits from the team to monitor her condition, adjust medications, provide personal care, and have visits from the chaplain. And then there was music therapy. She loved music. She was a music major and played in the Penn State Blue Band. The focus was now on providing comfort. The family was so relieved to have her in a safe place. They continued to visit frequently and to get her to family outings and, of course, shopping as she was able. Then one day there was a change. Some sort of spell, they called it. Not able to really communicate, vital signs are a little unstable. No real discomfort, but just didn't appear right. It appeared that death was imminent. The hospice team called the daughter and son and explained the changes. The family came and stayed and monitored over the next few days. The hospice team was there too. Nurses were carefully monitoring and providing guidance as to what was going on. Certified nursing assistants attending to her personal care, keeping her positioned and comfortable. The chaplain coming in to say prayers. The social worker attending to the needs of the family, checking to see how everyone was coping with the change. And then the physician that had cared for Sally for the last 10 years, who came in to say his goodbyes and let her know that she had been a wonderful patient, strong, never complaining, and had a wonderful sense of humor. He told her it was okay to go, that her body was very tired, her kids would be fine, and that they had all done a great job in caring for her. Then one evening, the daughter left about 8 p.m. to go home to her own family. At 1 a.m., the phone went off with the news that my mom appeared to be dying. I went to her room, found that she was definitely making the transition from this life. My brother arrived shortly after I got there, and an hour and a half later, my mom died in our arms. She was peaceful and well cared for. One of the greatest blessings of my life was to be there when my mom died. She was not alone. She was surrounded by love. Hospice made that happen for Mom, for me, and my family. Thank you.
So just a little bit about myself. So while I am the Chief Medical Officer for Vitas Healthcare, I am a geriatrician and hospice and palliative care physician. I continue to see patients in the home setting, in the hospital setting, and in one of our inpatient units in Florida. I think one of the most important roles a physician can have is being honest and truthful with patients and families about their diagnosis, the natural history of their condition, and then supporting them for a transition when end of life is approaching. No decision is harder, at the same time more fulfilling than to be able to help a patient navigate that end of life. To have an honest and open conversation about treatments no longer working, despite everything that's available to them, their disease continues to progress, and now would probably be the time for a different type of care, which is hospice. No physician, nurse practitioner, physician assistant takes that role lightly, and when that conversation happens, it's life-altering for the patient and for the family, and many times directly impacts the clinician. To be able to get and receive hospice services, a physician must attest that the patient has a prognosis of 6 months or less if the illness runs its normal course. Nobody takes that decision lightly. As you can imagine, nobody takes that conversation lightly. As a physician, when I'm with a patient, the things that I look at to try to determine whether or not I think somebody has a prognosis of 6 months or less is, number one, how is their nutritional status changed? Are they losing weight unintentionally? Are they having difficulty swallowing? Are they developing pressure ulcers? Then I think about their functional status. Have they been having falls with injury? Are they spending more time in bed? Are they not getting out of bed? Are they having more dependency in their activities of daily living? Does somebody have to bathe them, dress them, help transfer them? Maybe they're becoming more incontinent. Then I look at their cognitive status. How has their mentation changed? Do they recognize their family? Do they recognize their environment? The next thing I look at is their healthcare utilization. Are they accessing the ER for emergency care? Have they been hospitalized because of their conditions leading to their mortality? And then the last thing that we look at is, what are their symptoms? Do they have uncontrolled symptoms? Pain, shortness of breath, fatigue. We look at those general domains of impairment: nutrition, function, cognition, healthcare utilization, and symptoms in conjunction with their underlying diseases: cancer, heart disease, lung disease, dementia. And the combination of those two things is what helps a physician decide whether or not a patient has a prognosis of 6 months or less. After we make that determination and have a conversation with the family, the referral is made to the hospice. The hospice comes out and does a comprehensive evaluation and goes through all those domains I just listed in a very, very comprehensive way. Where was the patient 3 to 6 months ago? Where is the patient now? How are those domains changing? How is the underlying terminal condition changing? If the physician who made the referral and the hospice agree that the patient's prognosis is 6 months or less, if the illness runs its normal course, and the family and the patient agree to sign the consent that they want to focus more on quality of life than curative treatment, the patient enrolls into the hospice program. As Susan so eloquently stated, hospice is about individualized care plans. Believe it or not, when you ask somebody what's important to them about their health care, they can actually tell you. And not only can they tell you, they can actually prioritize their care. As Susan so eloquently said about Sally, what was important to Sally? Being at home, surrounded by her loved ones. 80 to 90% of people at the end of life, that's what they want. She had hobbies that she loved, shopping. So the hospice supported her in that goal to go shopping, right? So the interdisciplinary team, the nurse, the physician, the social worker, the chaplain, the counseling services, the certified nursing aide, they all work together to understand those priorities and to make sure that the care plan matches. That can sometimes mean very aggressive treatments. Recently we had a patient with end-stage heart failure who was on a medication called milrinone to keep his heart strong enough to live. He wanted to continue that treatment to try to get a couple weeks so that he could be at home. We were able to take the patient home from the hospital to be on his milrinone drip. He was on the drip for 2.5 weeks, started to get more and more confused. At that time, we were able to discontinue the drip. But what was important was, number one, he could be at home. Number two, he could be surrounded by family. And number three, he was able to be with his dog, and he wanted to die with his dog, right? So after somebody enrolls in hospice, we develop that individualized plan of care. That plan of care evolves over time, but at the first 90 days, the second 90 days, and then every 60 days thereafter, the team goes through what we call a recertification process, right? We look at all those domains I discussed: nutrition, function, cognition, healthcare utilization, symptoms, and disease-specific decline to determine, do we think on average this patient still has a life expectancy of 6 months or less if the illness runs its normal course? Again, that decision is taken very seriously. If we have questions or concerns, sometimes we may even reach out to the referring physician to get extra input on how the patient is doing. Each member of the interdisciplinary team helps participate in that process. If we believe the patient's prognosis is still 6 months or less, we generate a recertification as a physician to document to CMS why we believe in 6 months that patient will probably have passed. If we no longer believe that to be the case, then we relook at services, and then we would discharge the patient for extended prognosis. So again, I just want to reiterate, as a physician, one of the most challenging things we ever have to do is look somebody in the eye who has entrusted their care to us to tell them, unfortunately, we think their prognosis is 6 months or less, and it's now time for hospice. The gift of that conversation is that we can prioritize their care, they can figure out what's important to them, and we can support them so that they can get what's important to them, and that their care is consistent with their wishes and values. Thank you.
Hi, thank you so much for being here and giving us the opportunity to share with you some of the findings and insights from our recent NORC study. Over the next 15 minutes, I'm going to present some hard numbers and insights about the study, and then feel free to ask questions at the end. So I'm not going to belabor the NORC intro because Logan gave a great intro about that. In addition to everything that Logan said about me, I do have some experience with hospice and some of those care and the seniors housing care settings. I've been at NORC for 4 years in this healthcare strategy role. Prior to NORC, I was with Blue Cross Blue Shield Association in Chicago. And then prior to that, I spent a year at an organization called Attuned Care, which was a small startup in the Chicago area that was providing hospice, home health, and nurse practitioner services to people living in seniors housing, and I was their VP of quality. Before that, I spent 7 years at Avalier Health in the data analytics group, and then 3 years at RTI, where I worked on the post-acute care payment reform demonstration, all pre-health reform, so very different landscape. All right, so over the past year and a half or so, NORC has been working with NHPCO and NAHC on a commission study to assess the value of hospice to the Medicare program, specifically to the trust fund, but as well as to the Medicare bennies, their families, and caregivers. We conducted 2 phases of this work. One was a claims analysis, which much of the work that I'm going to show today is derived from, and then also a lit review to understand the benefit to the bennies themselves and their families and caregivers. In terms of the claims analysis, we did a comparative assessment, which really means that we looked at everybody who died in 2019, and we put them into a hospice category, meaning they actually experienced hospice, or not hospice. We looked back over their 12 months of life, and then we summarized all of their utilization and costs of care for that last 12 months of life. The comparison group of hospice, so this is really key. The comparison group of hospice was not just those all Medicare bennies. It was actually people who, I would say, looked like hospice users. So we looked at end-of-life conditions, many of which Dr. Shaga mentioned. We also looked at other chronic conditions. We looked at demographics. As much as we could get from their prior 12 months to put them in this category of who is eligible and appropriate for hospice. And then finally, to understand not only, did these people look like hospice people and what were the utilization, we needed to assess what was the potential savings to Medicare if non-hospice users had used hospice. And so we extrapolated the findings using some MedPAC work to understand, to calculate those findings. So the value of hospice study is one of the most statistically grounded comparative assessments of hospice spending to date. Part of the reason, it's threefold. So one, we looked at 2.3 million people who died in 2019. That's the largest study to date across Medicare, fee-for-service, and MA. We looked at 12 months of spending. So many other reports are looking at the last 6 months. We looked at the last 12 months. And lastly, and this goes back to something that Susan and Dr. Shega said, we looked at frailty. So many studies are limited to what's on Medicare claims. And so that usually leaves you with demographics and diagnoses. We looked at frailty as well, and that's things like functional status and cognition. Biggest point here is that the value of hospice study found that there were 3.1% expected savings in the last year of life for those who experienced hospice. And that translated to $3.5 billion in projected savings from the hospice benefit. There are 5 key takeaways. So the first is this point, that there is a difference of 3.1% in costs between those who experience hospice and those who don't in the last 12 months of life. That projected to 3.5. The study population, I said, we started with 2.3 million decedents. From there, we whittled it down to those who are appropriate for hospice, and we kind of took out the people who are not appropriate for hospice, and we had a population of almost 1 million people, segmented roughly half. So there were over 500,000 people that had hospice, and then they were kind of matched to about over 450,000 that were not hospice, but eligible. So I want to say that for 90% of hospice stays, hospice spending is less than half of total cost of care. Let me just say that again. For 90% of hospice stays, hospice spending is less than half of the total cost of care. Let me walk through this a bit. In that 12 months, when you go from hospice stays that are very short, so less than 15 days, all the way through over 266 days, that's a pretty long hospice stay, total spending decreases relative to the non-hospice users. So the top line shows the hospice component, that is the percent of that 12 months that's allocated to hospice spending. The bottom line is the difference with the non-hospice. So you'll see in the short stays, like the very, very short stays of less than 15 days, that's like less than 2 weeks of being on hospice, there's not much of a difference, and I'm going to talk about that in a moment. But as you move out, the longer the hospice stay, the more potential savings. Oops, sorry. I love this. Even when hospice care is 89% of total costs, that's far the majority of the hospice costs, spending is still 12% lower compared to the non-hospice. That's a huge difference and a huge value to Medicare. So I want to talk first about some of those short stays. There's potential that earlier transition to hospice actually helps defer some of the curative care that's not as valuable to patients and their families as hospice care. So if we look at this table, to the left we have the very short stays, again, 2 weeks, about 2 weeks or less, and then up over 266 days. We see for all disease groups, of which some Dr. Shega mentioned, but we also included circulatory conditions, respiratory, and CKD-ESRG, you'll see that on the left side, the shorter stays, the non-hospice group is actually less than the hospice group, and I'll get to that in a moment. But as you move out across all the disease groups, the hospice group was actually less than the non-hospice group. So here's where I want to kind of focus some of the attention. 55% of hospice stays are between 1 to 15 days, and actually, less than 6 days. So it's like at that last moment when people are feeling there's just really no more curative care, there's just no more solution, they transition to hospice. The challenge is that hospice The value of hospice is deferring some of that curative care, and they just don't have the opportunity to do that. And so the hospice is just added cost to an already really, really costly period of time. So what we found was at about 10 days, there's a break-even point where if people can enroll in hospice at least, day 10 prior to death and better over a longer period of time, there's more opportunity for hospice to provide that value to not only the, Medicare savings, but also to Bennies and their caregivers and families. One potential option here to both on-ramp and provide a level of care that's necessary in end of life is community-based palliative care. Community-based palliative care has the potential to improve end-of-life care and Medicare program costs. So rewind 3 years, NHPCO hired NORC to do an analysis and estimate the potential cost savings of a community-based palliative care program. So we used Medicare fee-for-service claims, looked at years 2017 through 2019 to estimate what is the potential impact of a new Medicare Care Choices model. So we nicknamed it MCCM+. What we found was about 10 million fee-for-service beneficiaries could potentially be appropriate for the MCCM+ program. What we found is there was average total costs of care of about $45,000 in that last year of life. But keep in mind that this $45,000 does not include Part D costs, and it doesn't include patient out-of-pocket like our new study does. So it's a little bit less, but once you factor in Part D and out-of-pocket, it's actually quite similar to the findings from this year. The palliative care program helps solve for some of the high rates of hospitalizations and ED visits that are driving up that cost in that last year of life. And what we found, so the NORC work we did found that there's potential, like another $500 million in potential savings for 346,000 potentially eligible enrolled beneficiaries. Oops, sorry. So there's about a 20% efficacy rate for the community-based palliative care program on top of earlier enrollment into hospice. There's a lot of research, there's a lot of work coming out about highlighting or putting a spotlight on lengths of stay in hospice that are greater than 6 months. And I want to spend a little bit of time here because we spent quite a bit of time on this work. What we found was, and you remember from that slide with the table, even as you go out, the further you go out, the longer the stay across all disease groups, there's value to Medicare for hospice. So across all disease groups on average, hospice spending was 11% lower than the non-hospice users that exceeded 6 months. 6 months is a pretty long length of stay in hospice, and there's still savings. And you can see across all the disease groups, some of them are really large. Cancer, there was savings of 17.5%, CKD and ESRD, about 25%. And then lastly, the work that we did on the lit review to understand what are the benefits to Medicare beneficiaries, their family, their caregivers, is that greater utilization of hospice during those last 6 months of life is associated with improved patient experience and clinical outcomes. So first, from the perspective of patients, there was less physical and emotional distress and better quality of life at end of life. Hospice admissions in the last 6 months of life were correlated with increases in patient satisfaction, better pain control, and reduction in hospital stays. From the perspective of their families, families remarked that patients received just the right amount of pain medication and help with dyspnea. Families of patients receiving more than 30 days of hospice reported the most positive end-of-life outcomes. And families more often reported patients' end-of-life wishes were followed and rated quality of care as excellent. From the perspective of their caregivers, home hospice reduced risk for prolonged grief disorder, and less risk of PTSD with home hospice deaths. So really quick on the methodology. So as I said, we started with 2.3 million decedents. From that, we whittled it down to about 950,000 hospice and non-hospice users. And we looked at average costs of care between the hospice and the non-hospice. We looked at by disease group, and we looked at the hospice episode length of stay. What we did was we adjusted these outcomes. So rather than just identifying people who were hospice users and non-hospice users, we drew this comparison group of the non-hospice users to look as much like hospice users as possible. I like to use the analogy of we created Frankenstein people. So there are many, many non-hospice users. Rather than find a hospice user and try to match with any one non-hospice user, we actually created profiles of a hospice user based on the aspects of the non-hospice user that were most similar to hospice users. So there are characteristics of non-hospice users that look most like the hospice. So are they older age? Are they female? Do they have one of these 14 chronic conditions? Do they have 2 or more end-of-life disease groups? Do they have a higher frailty score? Which means, are they more frail? Do they have lower functional status, potentially lower cognition? If so, they are more like a hospice user, and we are more likely to use them as a comparison group. And then the inverse is true. Are they younger? Are they male? Do they have only 11 chronic conditions? Do they have a lower frailty score? All of that would mean that they are less like one of our hospice users. The approach we used is called a propensity weighting. It's really just the fancy word for we created these Frankenstein individuals. And then, as I said, we compared the spending and the costs, and that's it. I'm sorry.
Thank you so much. Thanks to all 3 of you. Those were great presentations. Susan, for sharing that testimony. I didn't know that story. That's really powerful. And Dr. Shaker, I think you really painted such a vivid portrait of the process of how someone gets into hospice and what happens once they're on it. And thank you, Diane, for going into the weeds there. I got technical, but again, we're really excited about this research because of all that weedy stuff. We're that much more confident that the savings that the analysis found are truly applicable to utilization of the benefit and not other things that are floating out there confounded.
You're absolutely right that families don't get the benefit of the hospice delivery system at all with its short length of stay. It's really crisis management when you have to come in and support a family who the patient is dying, like literally right now dying. So that's a difficult situation for the patient, obviously, but the family as well, and the hospice team. And I think that we've been challenged ever since hospice was first conceived, I think, with this issue, but I think there's becoming more awareness of hospice. I think there's greater acceptance of hospice for folks now, and I'm hoping that with time we'll see greater improvement. I think that we still have the challenge, and I'm going to turn over to Joe for this one. Physicians, it's a very difficult decision to make. It's a very hard conversation, as you mentioned before. And they're really hesitant to do it. They'll sometimes leave it to the hospice to tell the family what's happening. So it really is a shame that we still see so many people come so late. Joe?
Yeah, no, well, as a geriatrician and hospice palliative care physician, I embrace honest, transparent dialogue and trying to meet people where they are. Physicians in general are trained to focus on cure and prolong life, and for some it's very hard to make that shift. Also, I think there's a lot of misperceptions about what hospice is and what hospice does because of those short stays, right? So when you have a short stay, the hospice does incredible work, intensive resources to try to meet them where they are, to get those wishes honored. Most people want to die at home, and it's like bringing the ICU to the home to allow that death to occur where they want it to be. So the doctor and the family see, oh, hospice is just in a couple days, and it's a lot of management of pain and anxiety. But if somebody would have had that conversation 4, 5, 6 months earlier, right, you could have avoided all of that trauma the family experiences and the patient experiences. You could have had an experience like Jimmy Carter is having now, where he's chosen, he wants to be at home, right? And there's no difference in life expectancy between people who enroll in hospice earlier versus those who don't, because curative care at the end of life is a fallacy. There is no curative care. It's all supportive care, and it's being honest about what do you want that care to look like and where do you want it to be. With hospice, you can provide that care at home. Without, most often it's in the hospital and in skilled facilities.
Well, I'm glad you brought up President Carter. I think that for folks in the room who've been following his hospice journey, it's unique. I think we don't often see someone, a public figure like that, talking about what his family, talking openly about the decision to choose hospice. You often hear after the fact, oh, this celebrity, this person was in hospice, and it's not articulated. So I think he's doing a real public service. And it's funny, Joe, you mentioned misconceptions, maybe driven by the fact that there are so many short stays related to President Carter. I saw there's a Twitter feed that someone started that's called Days Since Jimmy Carter Has Been on Hospice. And it was started just because I was following all the Twitter chatter about this, and it's because the public, just Twitter users, had such a misconception. They started it when he was on for 2 months, and they thought, oh, is he breaking a record for hospice? And so this guy started this thing, it's just a daily counter. So he's at 160 days right now. But I think that shows what a misconception there is about what hospice is, who's appropriate for it, and how it can be not just brink of death care. So thanks for bringing that up.
Well, we should open up to the room.
Oh, absolutely, yeah.
Do we have any questions in the room?
Don't be shy. Go. Oh, right, go ahead.
Yeah, so could any of you guys just talk to sort of the, I see the community-based palliative care demonstration model, just speaking to the legislative ask there, and what that looks like from the congressional side?
Sure. You want to handle that one?
Dave's here at the microphone.
Yeah, sure. So, and I'd actually like Susan to weigh in here because of the MCCM experience. And yes, there is, we advocate for the testing of a new community-based palliative care demonstration out of CMMI, Center for Medicare and Medicaid Innovation. There is legislation in the Senate right now, Bill 1845, the Expanding Access to Palliative Care Act. Hoping to see a House companion soon. Excuse me, but that bill calls for CMI to test I think, Diane, you said the MCCM 2.0, and
Yep.
in the research you've done, that's kind of what this bill calls for. It would build from the Medicare Care Choices model, which is the MCCM, which was a community-based palliative care-like model. Maybe not exactly how everyone would define community-based palliative care, because you still had to be hospice eligible, but that model was one of only 6 in CMMI's entire portfolio of 100 plus, I believe, they've launched since their genesis, that met the statutory criteria for expansion in terms of improving or maintaining quality of care and driving savings to Medicare. We'd love to see CMMI do something more on that, and that's what this bill is about. And we really think that testing the next generation of it that is more community-based palliative care-like would allow us to sort of see what a sustainable payment and care model would do for this population. And we also think it would most likely result in driving more timely access to hospice. The MCCM evaluation itself did show that 70% of the savings that were derived from the model resulted as a result of more timely transition to the hospice benefit. And Susan, I know you participated in that model.
Yes, our organization did
part.
participate in the demonstration, and we found that it was a demonstration that showed a lot of value from the caregiver's standpoint. They were very satisfied with the services that they were provided. And as you said, cost savings, a lot of that, I think, is driven by the intervention of the team to support them and have the tough discussions about goals of care that are hard for all of us to do, but they're necessary. And that kept people from going to emergency rooms or seeking care that really, as you said, was not helping them, really. The other piece of that is going out of my head as I'm thinking about it, but I think the MCCM was a small sample, and I think we see the benefit of being able to serve patients sooner. The other piece of the MCCM allowed people to continue with their curative therapies, but it was interesting how many converted to hospice so soon once they got in the program. So they didn't pursue all that. That
Right.
was really the bottom line.
Right,
So
right.
we're anxious to see if we can get some traction.
Right, and that's what that bill is about. Any other questions? Please.
Just want to ask about the provision of these services. Diane, I guess this is a workforce question. You said the research is based on those who experienced hospice, and Susan and Dr. Shega talked about like the care teams. You know, we often hear a lot about workforce issues in general, and not only in healthcare, like in airlines and in construction. And there are folks, at least on the Senate side, who are working on this in the healthcare space. But you know, does that have an impact on what this study would show in terms of what's going on? I mean, I know that this is a retrospective study, right? But now there's any ideas of how like a workforce issue would impact what this is saying about hospice?
Well, I think what, that's a difficult question, isn't
Right.
it? But I think workforce has been an issue for hospice as everyone has experienced, and particularly, this is not, it's not easy work. I mean, so, and trying to find the right people for these jobs is critically important to sustaining capabilities and everything. But retention has been the bigger issue going forward here, that really, most of us in my role, we're really concentrating on keeping the people we have, because it does become an issue of, you know, your true capacity and be able to care for people.
Yeah, I think what you see is a convergent of pieces that come together, right? Short lengths of stay in hospice is not good for patients and families. They derive benefit, but it could be better. It's much harder on staff because they have to do so much death work for the patient and family to try to meet their goals and make sure they achieve them, which leads to more burnout. And the NORC study that shows longer lengths of stay are associated with better outcomes from the qualitative review, greater than 30 days, better symptom management, better satisfaction with care, and then also from a cost savings perspective. So to me, the focus of workforce is focusing on the entire health system to allow for earlier hospice access, and that will help mitigate some of the workforce challenges, but in the end, will continue to derive the findings of the study, which is cost savings.
Right.
And I mean, workforce constraints are always going to squeeze, you know, the ceiling on value, I think, in any program, right? So the extent that every sector right now is experiencing those, hospice is no different. Palliative Care and Hospice Education and Training Act, PACHETA, this legislation that has been reintroduced in the Senate this year. It's a bipartisan, very popular bill. I think it's on its 12th year, 11th year. It's an oldie but goodie. We're really hoping we can get it past the finish line this year. It's a small drop in the bucket, $100 million that will go towards hospice and palliative care education. Again, you know, teaching some of those upstream providers, those referral partners, physicians, oncologists, and the like, about hospice, how to have goals of care conversation, so that hopefully, you know, they're skilled enough to know when someone's appropriate for hospice, when someone's appropriate for community-based palliative care, and we can begin to metastasize these skills throughout the entire healthcare system. In the back, please.
This question is for Diane. You've done a lot of research on healthcare, both delivery but also on the spending side. What most surprised you in your findings in this study?
I think there's this one statistic that I showed. It's probably why, if I can go back to it, it's probably why I called it out in here. Sorry. This one, where I don't know that we expected, there's so much, I guess, like controversy over long stays. And so I think going into this research, we didn't know, and maybe we would have assumed that the long stays were going to end up costing Medicare more money. And what we found was actually the opposite. And so much so, like, I wrote the narrative on here, I drew the animation because I think it's really important to say, like, even when hospice is 89% of 12 months of spending, it's still 12% less than if people didn't use hospice. And so that deferring of care, and then you add the fact that Medicare, the beneficiary, the caregiver, it's just a more positive experience overall. Like, together, it almost feels like a no-brainer. We're talking, 266 days. Like, Jimmy Carter has another 100 days to fall into this column. So I think that was probably the most surprising, and honestly, probably the most counterintuitive going into the research.
And just to follow up on that point, talking about longer hospice lengths of stay, there's been such increased scrutiny around increased lengths of stay. Even though the average is 15 days and only about 14% live longer than 6 months, we know prognosis is uncertain and we do our best, but patients are caught in the middle. And I give this example of a colleague of mine who I have utmost respect for, whose mother has end-stage dementia and is in an assisted living facility. She can't bathe herself, she can't dress herself, she's incontinent of bladder and bowel, she can't transfer anymore. And she had been on hospice for 6 months, and because she wasn't quote-unquote declining in her nutritional status, they discharged her for extended prognosis, because they were afraid that they were going to be at risk for an audit post-payment review. Now, because of that decision, every time the patient falls, which the patient falls probably once a month, she has to go to the emergency room to get a workup. So for our most vulnerable end-stage dementia patients, and such a hyper-focus on length of stay, we are start to see these adverse outcomes where, number one, dementia patients can't access the benefit, and then number two, we're inadvertently causing harm by making these patients go to the emergency room and receiving care that's unhelpful, whereas if they could just stay on the benefit where they truly are still eligible, we would have that win-win situation of decreased total cost of care and improved outcomes.
That's such a great point, Joe. Thank you for raising that. I know it's a lot of hospices are frustrated with that hyper focus from the audit and regulatory side on if you're 180 days beyond, then we're going to come after you and so on. It's making it really hard to operate for a lot of folks out there, which is counterintuitive because I think that hospice started right as a cancer benefit, and now we're serving so many more non-cancer patients who have more unpredictable trajectories. That's a real win for the benefit. I mean, to be serving that diverse community, they might tend to be the ones who might have those quote longer lengths of stay, but as NORC has shown, they're still driving both quality of life and fiscal benefit to the program, to the community. So thank you for drawing that out. We have time for about one more question if there's any. Oh, yeah, please.
I just have a quick question.
Yes, please.
What was the name of the bill that, with the $100 million?
That's the Palliative Care and Hospice Education and Training Act. PACHETA is the acronym.
Okay.
I don't know the number off the top of my head, but do you know the number, Logan? We'll get that to you.
I'm looking it up.
Okay, perfect. Lucy's gonna
It's Senator Baldwin and Capito introduced.
Okay.
Like I said, it's been around for a long time, and it's almost got there a few times. I think it had 260 plus.
4263.
Oh, we got.
On the Senate side and 2243.
Perfect. Thank you. Thanks for the question. Any other questions? Going once. Okay, great. Well, thank you so much. Please, a round of applause for our speakers.